Good afternoon, everyone, and welcome to this UCL East Lunch Hour lecture. We are pleased to have you all with us today. I'm Paola Lettieri, Professor of Chemical Engineering at UCL and Director of UCL East, our new campus that is being built on the Queen Elizabeth Olympic Park in London, and we open next year. So our speaker today is Helen Chatterjee, Professor of Biology in UCL Biosciences and UCL Arts and Sciences. Her research includes evidencing the impact of natural and cultural participation on health, and she's an advisor to the All-Party Parliamentary Group on Arts and Health, and she also chairs the Royal Society for Public Health Specialist Interest Group in Arts and Health. Helen is also a founding trustee of the National Centre for Creative Health. She has won a range of awards, including a special commendation from the Public Health England for Sustainable Development and the 2018 Arts and Humanities Research Council Wellcome Health Humanities Medal and Leadership Award. And she received an MBA in 2015 for services to higher education and culture. So the talk today is part of the UCL East series because Helen is launching this September a master's degree of Arts and Sciences in Creative Health. It is the very first in the world in this discipline, and the program will be moving to UCL East in 2022 when we open. So before handing over to Helen, let me remind you that you can post questions on Slido, and the code is LHL2, and we will answer questions after the talk. So Helen, over to you.
Thank you, Paola. Thank you for your very kind introduction. It's really lovely to be here. I'm really sorry that I can't see all of your lovely faces, but I hope you're all doing well, and I hope that you're enjoying Mental Health Awareness Week. And the theme for this year's Mental Health Awareness Week is nature. So I'll be covering some aspects of why it's good to engage not just with nature, but all aspects of creative health to keep our own mental health good. So I'm going to talk a little bit about our work around creative health and research that we do around this area and social prescribing, in particular in relation to health equity. And then, as Paola says, I'm going to talk a little bit about our master's programme and invite you to an event that we're doing later on if you'd like to find out more about the Masters in Creative Health. So I'm just going to hope you guys can hear me okay. Oh, there we go. So let's just start by thinking a little bit about health inequalities. Well, this is a term that we've heard a lot more about, isn't it, over the last year or so, largely due to the COVID-19 pandemic. And that's really thanks to, I think, the work of Michael Marmot and others who've talked a lot about how the COVID pandemic has adversely and disproportionately impacted vulnerable members of society. And by vulnerable, what we mean is people who've got physical, psychological or socioeconomic challenges in their life. And the Marmot Review's report, COVID-19 report, Build Back Fairer, really clearly articulates how people who are living in poverty, receiving low wages, or who are a member of a single parent household are much more likely to be experiencing health and economic impacts as a result of coronavirus. And if you can look at this chart here, you can see that COVID-19 has been killing people in the most deprived areas at double the rate of those in more affluent areas. So we know then that the area that you live in, the geography and the surroundings that you live in have a significant impact on your health. Because that's not new. We've known this for over 10 years, thanks to the work of Michael Marmot and others, who showed that we know that there's an impact of the social gradient on health. As these charts here show, we know that inequalities, as Michael Marmot said, arise because inequalities in society, in the conditions in which people are born, grow, live, work and age. So it really doesn't matter what variable you look at. Here we're looking at incidence of cancer, heart disease, injury and suicide. And each of those different coloured bars on the bar chart indicate different socio-demographic groups from people. And what we can see is that people from the category D, who live in the most deprived areas, who are the poorest people, have much higher incidence, no matter what variable we look at. Things like cancer and heart disease are much higher for people who are basically poorer. So that's what we mean when we talk about this social gradient on health. And that was really what Michael Marmot and others talked about in the Marmot Review from 2010, which is now over 11 years old. And what Marmot said is that a range of social factors need to be taken into account if we want to alleviate health inequalities. And we know that the NHS alone cannot reduce health inequalities. And of course, that's even more paramount at the minute, as we know the significant pressures that the NHS has been under due to COVID, and that's likely to have lasting effects over a number of years. But what we also know is that social networks and local communities strongly influence individual health and well-being. The situation hasn't really changed much over 10 years, except that it's got a little bit worse. What the Marmot Review 10 years on showed was that there's been a slowdown in the increase in life expectancy, and that we're continuing to see an increase in inequalities in life expectancy between more and less deprived areas. We've also seen big increases in regional differences and a decrease in life expectancy in certain regions. For example, women in the most deprived areas outside London are much more at risk of experiencing inequalities. So we've got some severe challenges in society in relation to inequalities. And that's why it's been increasingly important to try and understand these wider social determinants of health, because we know these wider social factors have such an impact on health. Here's some data just showing that health inequalities are significantly worse for people who are poorer, living in what we call asset poor areas. So here, these data shown by ethnic group are explaining the links with private garden spaces. And again, if you're a poorer person living in a poorer area, you're less likely to either have access to your own private garden or good quality green or blue spaces like parks or coastal areas. And the same goes for any other types of community assets that we might look at, things like libraries, museums, other types of community resources. These are all much worse for people who are living in poorer and more deprived areas. So we know that there's a positive correlation between greater access to these sorts of assets and spaces and reduced health inequalities. So that's why it's really important to understand what we mean by community assets. And this was first introduced by Foot and Hopkins and referred to a lot by Michael Marmot and his team. And Foot and Hopkins said that as well as having needs and problems, our most marginalised communities also have social, cultural and material assets. And identifying and mobilising these assets can help overcome health challenges that they face. So there's loads of fantastic data and evidence that supports this. Some of you might be familiar with more integrated healthcare systems like the Bromley by Bow Centre in East London. And here this is a health centre, GP centre basically, which combines primary care with a whole load of community assets and resources. So as you can see from this great photo here, it's set in a park. So there's some lovely green space near the GP centre, but there's also lots of offers available around visual arts, dance, singing, theatre, book clubs. There's food growing, a food bank, and various aspects of community engagement and resources that are there to support the individuals using those services like the GP service, as well as bringing all those different services together through social prescribing. So for those of you not familiar with social prescribing isn't a new concept. In fact, it's been around for over 30 years. It's now a key component of the NHS Universal Personalised Care Plan. And the way that we describe social prescribing is it's basically a way for local agencies, local referrers to refer people to sources of support in their community. Now, this may include what we call a social prescribing link worker who may work for example, a GPs or a primary care network or a local authority, or indeed a third sector charity organisation. And what those individuals do is help people to focus on what matters to them. And it's basically about connecting people up with assets and resources in the community that can help them to support both practical and emotional needs. So the social prescribing pathway is quite complicated and it varies from place to place. Not everybody has a social prescribing link worker yet, but in the last year or so, the NHS has been rolling out a huge programme of recruitment so that all areas in England will have social prescribing link workers, and all GPs and local authorities will have access to a link worker eventually. But basically, the important aspect of social prescribing is this referral to an activity in the community or in the voluntary sector that specifically tackles these wider social determinants of health. So, for example, you may have presented at a GP with a particular problem, say a mental health challenge, or for example, you're having issues with your diabetes, or maybe you're obese, but maybe you've got also some other complicated problems. For example, maybe you've got housing issues or debt issues. And the issue is for those individuals who are facing the worst inequalities, they often have complex needs and a mix of complex problems. And that's why social prescribing could be particularly beneficial for those sorts of individuals with complex needs. So we've seen that social prescribing has emerged as a strategy for tackling health inequalities through this partnership, like you've seen with Bromley by Bow, between primary care and third sector organisations. And it's basically a practical way to provide this architecture to link people up more with their communities, which, as we know from the Marmot Review and other work, is really important if we want to tackle those severe inequalities. We've been working on social prescribing for a number of years now. This is just one study that you can see in this slide here that we worked on for 3 years, looking at the notion of using museums as a referral pathway for people who are older and experiencing loneliness or isolation. And I won't go through this particular project in detail. There's lots more detail on our website, which I'll give you at the end. But basically, we linked up museums in Camden and in Kent with individuals identified by local adult psychological services, local branches of Age UK, and other local health and third sector referrers, with local museums. And those museums ran a whole new programme of a 10-week intervention, each week offering activities of about an hour and a half, to groups of about 10 older adults who've been identified by those health services as having particular issues around loneliness. And most of those older adults that we worked with within the study were not regular users. In fact, most of them were actually people who were not going out regularly to cultural activities, or indeed many of them not leaving their houses at all, apart from perhaps going and visiting a GP or another healthcare appointment. And what we found across that 10-week intervention of doing these museum-based activities was that we found statistically significant improvements in psychological well-being. So we can see there that statistically people were increasing their health, but also the key thing that came out, I think, was this increase in sense of belonging. And the work that came out, particularly around our more qualitative aspects of the study, is people talking about an increase in their quality of life. We saw people referring to a new interest in learning and acquiring new skills, which is really important for all of us, but we know that that's particularly important for older people who might be facing, for example, cognitive decline. Really critically for tackling loneliness, we saw an increase in social activity and continued increases, for example, to museums and setting up actually their own social groups, meeting outside of the sessions and going for coffees together. And overall, people talked about an overall healthier lifestyle changes of getting out the house more, being more physically, cognitively, and I guess emotionally engaged, which was a really important improvement, I think, that we see with a lot of social prescribing activities. And we've continued our work around social prescribing and community assets in another project where we work across a whole team of people led by Daisy Fancart at UCL, where we're really focusing on how community assets, both social, cultural and other community assets, can be used to tackle mental health in our March network. So do go and have a look at that website if you're interested in connecting in with some of the fantastic work that's going on across the community sector to support mental health, not just around social prescribing, but also around prevention and other aspects of healthcare. I'm going to move on now to talk about what we've been doing over the last year, thinking particularly how COVID has affected our understanding of health inequalities and how community assets and creative health, and the notion of creative health in particular, might be able to support people who are experiencing health inequalities. This is a project funded by the Arts and Humanities Research Council and UKRI. And here we've been working with a whole range of different partners, from large organisations like Arts Council England and the NHS and Natural England, along with organisations like the Culture, Health and Wellbeing Alliance and a whole range of other universities. And what all of us have been really interested in is trying to understand how participants experiencing lockdown, self-isolation and shielding engage with community resources and what impact that has had on their health and well-being. So we've been collecting a whole range of different types of data. Most importantly, we've been asking people what they've been doing during the restrictions. We've been asking them to rate their health and well-being and aspects of different aspects of well-being, such as loneliness. And we've been doing some more follow-up interviews, so trying to get into the nitty-gritty of what it is that people have been doing, really to understand what works. And I'll talk a little bit about these results in a second. We'd linked up with some other surveys, such as the UCL Social Study and the Royal College of Music Studies, that have been also interrogating what people have been up to during COVID restrictions. And we've also done some more focused work, working with people who are vulnerable and shielding and the organisations supporting those people to, again, understand how COVID has affected people who are vulnerable and shielding and what sorts of community assets and resources work to support those people and how we might be able to continue that sort of work in the future post-pandemic. So we've identified literally thousands and thousands of resources out there. And maybe some of you have been engaging in some of these resources yourselves, I hope so. And there's a huge mix of stuff out there. A lot of material went online. So lots of organisations like museums, libraries and artists moved their work online to support people. But we also saw lots of organisations thinking creatively about how they could adapt the services that they currently run to support people, particularly who are more marginalised. So it's been really interesting delving into understanding what people have been doing. And this chart just shows you a snapshot really of what people have been up to during the pandemic. And as we can see, fitness and exercise and gardening activities seem to have been really, really popular. And we have seen lots of news articles about people engaging more in the outdoors, which is really, really brilliant. And we can see lots of positives from that. Also, people engaging more in crafts activities, reading, arts and cooking activities. We looked at how people have engaged in these activities. And usually, of course, people would be engaging with these activities offline with other people. But what we've seen is an increase in people doing more online work. But what has been really interesting is that our data has shown that people have been engaging with these sorts of community resources much more often than they had before the pandemic. So I think that's great news for nature and great news for other sorts of cultural and community assets, that people have, I guess, found a renewed love for these sorts of resources and assets and are keen to engage with them more. But we know that there's both positive aspects and negative aspects to engaging with that. And we also know that there are significant barriers for some people in engagement. Here's just some of the positive aspects of engaging that people talked about. We know that fitness and exercise, people have valued that in terms of keeping good mental and physical health. People have enjoyed focusing on creativity to distract them from other worries. Connecting and sharing and keeping in touch, of course, has been really important. Something that has cropped up time and time again is this challenge of how to keep yourself occupied and giving structure to today. And we've seen that these sorts of resources have been really important for that. And again, learning and acquiring new skills and keeping the brain active has been really important. People have also, though, have talked about some of the negative aspects of engaging with activities. And I think some of us can all share in these sorts of outcomes. So increased issues with eye strain, aches and pains and injuries, perhaps from taking up new activities that we haven't done before. Or, for example, like many of us, if you've just been sat in front of a computer screen all day, as opposed to getting out and about as much as you used to. Lots of individuals have talked about some of the challenges of being able to access these sorts of activities, especially if they're online, that they have a cost element, some of them, and it requires them to buy tools or materials. And in some cases that might include, for example, not having had a computer. A lot of people have talked about the issues of these activities, especially if you're on your own, being solitary. So you may be able to connect with somebody online and you may see lots of nice faces online, but that's still, of course, very different to the sorts of physical contact that we know that people need. and other issues around some of the online platforms, people being able to access those and difficulty using them. So it's been really interesting, I think, to understand what some of those challenges are, but also to delve deeper into understanding what some of the barriers to participation are. And I won't read through all of these. Actually, many of the participants we spoke to, both vulnerable and non-vulnerable alike, talked about barriers to participation. But we know, particularly for people in vulnerable categories, that there are issues around access to digital literacy. So they may either not have a computer or a smartphone, or, for example, have good Wi-Fi. Or even if they do, they may not have the necessary skills to be able to access Zoom or other sorts of resources. Also, a limited range of opportunities that are specifically targeting people from vulnerable backgrounds. So here we found it was really important for organisations to have a good understanding of what we mean by vulnerabilities and what those challenges are that those sorts of individuals might be facing. Issues of, as we've talked about, around finance, issues with activities being solitary and difficult to engage with if you're on your own, and requiring self-motivation and concentration. So this led us to looking more detail at what people have been experiencing in terms of loneliness and isolation. We looked specifically at the RUCLA 3-item loneliness scale, and here we found that slightly higher levels of loneliness compared to average levels pre-pandemic. And those people who felt most isolated were between the ages of 30 and 59, but the people who felt most left out were in the age category of 60 plus. So what we found was that the more people engaged in resources, however, there was a direct correlation between well-being and loneliness. So we found a decrease in well-being, which was significantly associated with increase in loneliness. So when people were more engaged in activities, those feelings of well-being increased and loneliness decreased. We're also really interested to look at those organisations and individuals who've been supporting, in particular, vulnerable members of society. So we worked with a whole range of different professionals, both health and community professionals, such as social prescribing link workers, public sector workers, third sector, charity and community professionals. And they talked to us a lot about the different sorts of ways that they've been working during the pandemic. And we found some really interesting examples of new and interesting, what we might call creative health partnerships, of community organisations working in different ways, say with food banks or local at-risk registers, to help identify who the vulnerable members of their communities were, and then understand how best to support those individuals. Many of those individuals felt that their work positively impacted participant well-being, but that they felt that the impact measurements that they're currently using do not accurately reflect the work that they're conducting. And there's lots of different ways that individuals are collecting data about participant engagement. People use things like the Warwick-Edinburgh Mental Wellbeing Scale, but there's many other different measures out there that we're using across health and social care. But I think it's a real worry that those sorts of measures that we're currently collecting don't accurately capture how participants, particularly those experiencing vulnerabilities, how they're engaging in their communities. So that's really led us to thinking about, we need to really identify new ways to capture that participant feedback and really understand how best to support individuals supporting and their vulnerabilities. Link workers in particular have been talking to us about the disparities that they feel between the job description and their day-to-day work. And I think this is really speaks to the impact that COVID has had on their work. For example, as you can see here, one saying that they wear several hats, from social worker to teacher, and most recently vaccine coordinator. So we can see how many different individuals, healthcare professionals working in a community, how their role has shifted. And that notion of becoming social workers really came through time and time again when those sorts of professionals were talking about the work that they do. So the key findings from our study have been that these sorts of creative health partnerships that we've been talking about can be really, really valuable. And they've led to unexpected collaborations that can really help to support vulnerable members of the community. But that despite this work, many individuals, both at the provider end and the healthcare professional end, and those participants, still feel that there are significant barriers to participation. So I think that's something that we've really all got to think about in terms of how we can redress inequalities and how we can tackle these issues around access. We've seen a massive surge in social prescribing referrals, which I think is really great in order for getting people linked up to the services they need. But there's also significant challenges around that, in terms of the provision and what's available, and also the capacity that those link workers who are doing those sorts of referrals might be experiencing. And I think that really reflects the changing needs of the health service. And all of this really speaks to the fragility of what we might call this community ecosystem. So obviously communities are complex places. There's lots of stuff going on in them, and there's lots of potential assets that are available in communities. But we know that those number of assets and the access to those assets is much worse in poorer and more deprived areas. So you may be living in an area with very few assets. You maybe don't have a library or a museum, and maybe your green spaces and parks are not places that are safe to go or that you feel safe to visit. So we've really got to think about how to make best use of the assets and how to deploy those assets better for the people who need it most. And that's really the focus of our work going forward. We're working in partnership with two major national organisations, the National Centre for Creative Health, which we've just launched, and the National Academy for Social Prescribing, where I'm part of the team where we're looking at the academic consortium of trying to bring together the evidence-based understanding and advocating for social prescribing. And what we're really interested in is how community assets and social prescribing can be repositioned to support individuals who face the most severe inequalities. And how can these systemic barriers to access be addressed to deploy our community assets more effectively? And in areas of deprivation, how can we improve the quality of those community assets? And as you've heard, there's lots of great stuff that's happened during COVID in terms of access to community resources, and some brilliant resources that have been made available for people. So how can we make those sorts of types of provision available for more people post-COVID, and what lessons can we learn to take forward that provision in the future? And then finally, how can we have more partnerships between academia, policy and practice? And that's exactly the sorts of work that's going on with the National Centre for Creative Health and the National Academies for Social Prescribing. And I think it's only through those better links between those organisations that we can better support people who are experiencing the worst inequalities. And to that end, that's why we decided to launch a completely new master's programme at UCL, which Paola mentioned at the beginning. So our new Masters in Creative Health will start in September this year. And here we're really looking to create a new generation of what we might call socially engaged scholars and practitioners. We talked about the changing needs of health and social care in the voluntary third sector. And we know that personalised care is a really key part of that, as well as opportunities around social prescribing to tackle health equity and try and improve the patient experience so that that can all be mainstreamed into public health. So it's not just nice to have for a few people, but that it is specifically targeted at those experiencing the worst health inequalities and those people with complex needs. So the notion of creative health comes from the all-party parliamentary group, which Paola mentioned at the beginning, for arts, health and wellbeing, the Creative Health Inquiry report. So if you want to know more about creative health, this is a great place to start. And as you can see here from the Right Honourable Lord Howarth of Newport, who set up and co-chairs the APPG for Arts and Health, that the response of our new MASc in Creative Health is directly addressing recommendation 8 from the Creative Health Inquiry report, which specifically says that we need more education and training opportunities to try and bring opportunities for increased understanding around creative health and the benefits of arts and creativity and community assets to health. And that's exactly what we're hoping to achieve with the Masters programme. As Paola says, this is the first taught programme of its kind in the world, and it's a completely new qualification as well. We've launched a new Masters in Arts and Sciences. And the reason for that is really recognising the interdisciplinary nature of this type of study. So we're really bringing together the fields of arts, humanities, sciences and medicine, and that will be really reflected in the programme. So to sum up then, creative health, it really means creating the conditions and opportunities for art, creativity, culture, and indeed nature to be embedded in the health of the public. And if you'd like to know more about the MASc, please do join us at our information session this evening, which we're running through Zoom. You can look at the Eventbrite link. We're going to be posting that to you soon. It starts at 6 o'clock. So if you're interested in knowing more about the Master's Programme, come along and have a chat with us and we'll share some more details about that. But meanwhile, just to say thank you very much for your time and attention. And I'm looking forward to having a chat and finding out what your interests are and answering any questions you might have. So over to you, Paola.
Thank you very much, Helen. This was really fantastic. We have got a few questions on Slido, so I will read them out to you. So Sarah wrote, I think social prescribing and integrated approaches are fantastic, but I question how they really address the poverty. Surely wealth distribution is the key?
Yeah, really good question. I mean, absolutely. And I alluded a little bit to some of the issues around areas of deprivation. And we know that, you know, certain geographic, I'm from Blackpool. Anybody who's ever, give us a wave if you're from Blackpool. We know that certain areas, Blackpool in England comes out top of the worst place to live in terms of public health outcomes. And Blackpool is a sort of typical example. I grew up just next door to one of the largest council estates. My sister still lives there. And when you're talking about areas of deprivation and we're talking about poverty, we're really talking about those, as Marmot says, the surroundings that people are living in. So it's all very well talking about tackling health inequalities, but until we improve those lives of those individuals who live there, and that includes the environment that they live in, so the housing that they live in, the access to training, jobs, the access to services, the quality of those services, then really nothing will change. And, you know, we know that years of local authority cuts have had quite significant impacts on the poorest communities in the UK, and indeed that the same data goes for across the world. So we know that investment in communities, we know that investment in community assets is really, really important. And if we invest in those sorts of assets and critically we address barriers to participation, then we might have a chance. But really, until those investments happen and we really shift the way that the funding is distributed at the minute, then there isn't going to be a big change. There are, however, I think, new exciting opportunities that are routes to change going forward. One of those is the new integrated care systems. And I've been talking about creative health partnerships. And this, I think, is a real opportunity. These, the integrated care systems, for those of you who are not familiar with that, are completely new ways that health and social care services are going to be coordinated and delivered in the coming years. There are already some that have been rolled out. And it's basically a way to connect up all those different services, including things like the NHS trusts, the primary care networks and GPs, along with, for example, services within local authorities like adult psychological services or social care, along with things like housing, the parks department, tourism, culture department. So it's really about how can those sort of better link-ups that are going to be essentially forced on us through integrated care systems, which I think is a really good thing. How can that new type of partnership working, how can that benefit the people who are experiencing the worst inequalities? But that really requires, I think, a really big shift, because at the minute, those services are not set up to respond in that way. They're very reactive. And so we don't at the minute deploy those services to tackle the social determinants of health. They tackle individual problems as they come up. So you've got individuals who are accessing multiple services. They might be accessing housing, debt advice. They might be regular visitors to their GP. They might have regular visits from social workers. They might have regular access to a whole range of other social services. But none of that is connected up for those individuals. And really what that speaks to is that again, these people who have individual complex needs, they really ought to be prioritised, and those ought to be our individuals that we're caring for and prioritising most. So I hope that answers your question, a really great question.
Thank you, Helen. I'll read out a comment which I guess is from the same person. It says, once people are out of deep poverty, then certainly these integrated models would be great for all levels of society, not just deprived areas. So the question, so I'm not sure whether you want to add anything, or otherwise I shall move to the next question.
Yeah, well, I think just, yeah, I absolutely agree. And integration, I think, really is the key. But again, it's only if those individuals with the greatest need are placed at the heart of those systems. So that requires a completely new way of thinking. And there's some great examples. West Yorkshire Partnership, they do some brilliant work in this area, really targeting individuals with complex needs, targeting people with inequalities. And thinking about how best to support them. So there are ways of doing it, and there's some great examples. And if you go to our the National Centre for Creative Health, you can see some of the work that we're doing there, that we're going to be linking up with our Masters in Creative Health as well, around working directly, collaboratively with these integrated care systems that are really collaborative and are already forming fantastic creative health partnerships. So go and check that out if you're not familiar with it.
Thank you, Helen. We've got lots of questions popping up. So the next one, does the course focus more on social prescribing in the first world context, or does it explore changes in the approach based on different wealth distributions?
It's definitely not a focus only on social prescribing, and social prescribing really is one referral pathway for people to be able to access what's in their communities. But for some areas, social prescribing will be very new. So within the master's program, it's definitely not just about social prescribing. Really, what we want to do, both at the scholarly end, is we're setting the scene for understanding what we mean by inequalities, understanding that data, and understanding what people's lives who are experiencing inequalities are like. And then what routes can we identify to best tackle those solutions? And that's where, we're really lucky within the master's program that I've talked about 2 partners who we're working with, but we've actually got a huge range of different partners who we'll be working with on the master's program. Some of those are big organisations like you've heard, like Arts Council England or the NHS, but through to local partners, so local city farms and local museums and artists and artist collaboratives. And those are partners that we've been working with for a few years, both on research and teaching, and they just do brilliant work in the community. And it's really, I think, working with those sorts of community organisations and individuals who are, if you like, at the front line of understanding their local communities and understanding what their needs are, that we're going to best understand how to tackle the social determinants of health. So the programme is very much set up to sort of bring together, if you like, what we already have and we know from the research and evidence base, together then with practice, and then also what we can do then at the policy end. So we're trying within the master's programme to really bring all of those 3 aspects together, and the students will hear from all of those different sorts of individuals, people who are working at a policy level within a national or strategic organisation, through to then community professionals who are at the front line delivering programmes and services, through to, really importantly, we're really lucky to be working with the Lived Experience Network, and that's a national network of individuals who bring their own lived experience to understand kind of what works in communities and community ecosystems. And so we're running a module specifically with them that's about bringing in individuals who will basically share their own experiences from accessing multiple services, for people, for example, who've been carers, for people who've been facing their own personal challenges, but then who've found solutions and are continuing to get support through, for example, engagement with arts and creativity. So again, those participants are, I guess, the best people really to talk about creative health, because they can really articulate it so much more beautifully than I can. I'm showing you loads of graphs, in their own words. And so I think that is a really brilliant opportunity for the students.
Great. So the next question is about the research, and did it show differences in engagement in social prescribing activities by men and women? Any opportunities for linking arts to sports activities?
Yeah, it's a good question. And actually, regularly what we see is that women tend to engage much more regularly in, not just arts and creative activities, but generally, not so much in sports. We do see some gender biases there, but in terms of social prescribing, a lot of social prescribers, providers and link workers talk about the issues around getting men involved. And some of you might be familiar with some of the fantastic programs like Men in Sheds and Hen Power, specific programs that are targeting this issue that we know about male participation in communities. And that is really, really important. So again, the more sorts of initiatives we have like that in communities, we know that that will have some big impacts for individuals.
So is social prescribing something that will eventually be commonplace? Is it being funded for the long term?
Yeah, really good question. Well, as far as we know, yes. In fact, Matt Hancock came to talk to the National Academy for Social Prescribing was launched, in fact, just before lockdown happened last year. And as I said, that there's been a huge surge in social prescribing referrals, I think partly as a result of the increase in numbers of link workers that have been appointed across England. But also, I think as people have become more and more aware of what's available in their communities, or at least an interest in getting involved in that, an increased drive from participants wanting to access wider services because of the challenges that the pandemic has faced them, both in terms of, for example, that might be economic, but also mental health. So I think the answer is yes, we really hope it will continue, but there's still a lot of work to do. You know, as you've heard, the link workers are under a lot of pressure, so a lot of them are coming on stream. There's new appointments happening all the time, but many of those individuals might be quite new to social prescribing, and it really only works if it's connected up with what is happening in the communities. So there's still a lot of work to do at local levels of that mapping work of scoping what is available in the community. And here, I think, is where we can all help. You know, it's where individuals and community organisations can reach out, and vice versa. Health, social care, link workers can reach out and make better connections with what is in their community. So if you're involved in a community organisation and you're not linked in with your link worker, you don't know who it is, then do a bit of research and make contact with them. And I can promise you they'll be really pleased to hear from you. And I think, you know, what we've seen from the work that we've been doing over the last year, many of those link workers are so pleased when they do say that, you know, community organisations are making contacts with them. And we've seen more and more evidence of both participants and all those different stakeholders, if you like, working together to co-produce really excellent programmes. And I think the more examples that we see of that, the better connected up that we'll see across communities. That can only be a good thing. And just to say, yeah, that Matt Hancock did promise another, I think it was 5 or 7 million for social prescribing over the coming, I can't remember what the timescale was, 2 or 3 years. So definitely for the foreseeable future. But I think it's up to all of us, you know, to be driving that, both at the referral end, you know, GPs and other healthcare professionals, but also community organisations to be thinking about how they can adapt the services, if they haven't already, to support people with the most vulnerable and complex needs in their society.
Absolutely. So talking about link workers, then the next question says, what support do you think could or should be in place for link workers? This is an issue as many can feel like low-paid social workers with no supervision.
I absolutely agree, and that's something that came through from a lot of the link workers we spoke to. You know, a lot of individuals, they're working really, really hard with some of the, you know, people who've got really complex needs, and we absolutely must support the people who are doing the support, like the link workers and those frontline healthcare professionals. And I think link worker health, the health of and well-being of those particular link workers, we really need to factor that in. And we are starting to see actually some of those creative community arts organisations thinking more specifically about how they can tackle that particular issue, you know, link worker burnout. We've heard of other sorts of healthcare professional burnout, and definitely that came through in the interviews we were doing. And giving the training, I think, obviously a master's course is not going to be available and appealing to everybody, but I think we are going to see many, many more training opportunities. We've just been meeting and talking with an organisation called Performing Medicine. They've been working in East London and North London on developing some new social prescribing training. There's obviously loads of training available on the NHS social prescribing website, but actually I think, again, the sessions that we've been running with our community organisations, when the link workers come to that, they often say how useful those are, to have that first-hand experience of kind of what works, understanding how to evaluate and evidence the impacts of the work that they're doing and the work that the providers are doing. So again, I think more partnership around training between community organisations and link workers, that has to be a really good thing.
Excellent. So the next one is an offer to help. So they say, I'm from Artlift in Gloucestershire. We do arts on prescription, and social prescribing is huge here. We would love to help with student placements if we can.
Brilliant. Well, what a fun. Thank you, Artlift. They're great friends of the National Centre for Creative Health and the Culture, Health and Wellbeing Alliance. So brilliant to hear from you, and lovely to, sorry, I can't see you, but, and Artlift's just one of, you know, a number of organisations. If people want to find out more about programs like Artlift, have been around for many years, and so social prescribing isn't new. You can go and have a look at the sorts of work that these brilliant organisations do. Arts and Minds is another one we've worked with for many years, who've been doing social prescribing for a long time and really understand what works. So again, for link workers out there, that's a great place to go, you know, have a look and go and have a chat with these folks. Thank you, Artlift, for your offer. And again, I think in terms of the master's programme, one of the real assets, I guess, for us is we've just got some wonderful organisations who've been offering to host our research projects. And the research projects is really an opportunity for an organisation, thank you Artlift for offering, and other organisations who will basically identify a particular need in their organisation that they would like tackled through a student research project. This is actually a type of community research project that we've been piloting within our MASc, our undergraduate degree programme, for the past 3 years. So we've had students working with city farms, we've had them working in museums, they've been working with individual artists, with other sorts of community organisations. And the sorts of work that they've been doing includes things like evaluating and evidencing, for example, how participants have experienced a programme. That students have been working on, for example, helping to develop new programs, identifying new participants, connecting, making different connections and networks within the community or with other organisations. They've been doing things like helping to draft policy documents, application forms for funding, writing annual reports. So really using the research skills that they gain in the taught parts of the programme to support that community organisation. And I think that's been genuinely beneficial for those organisations. And we've really seen the students have really enjoyed and benefited that first-hand experience of working with a community organisation, working with people with lived experience to think about, again, how we make connections across research and practice and policy. So if there are any other organisations out there who think they might like to host one of our wonderful MASc students when they start their dissertations, which will be around April next year, and they'll work on that for around 5 months. So you get a fantastic student who's been through the training of the taught modules and then can apply those skills to come and support you in your organisation. So do give us a shout if you'd like to get involved.
Wonderful. And it sounds like there is plenty to do. So do you think social prescribing could help with childhood obesity? Perhaps using schools as health hubs, using schools as a screening and resource hub. What do you think, Helen?
Absolutely. I mean, one of the challenges that we've seen is, cuts to in the curriculum to things like physical exercise and arts and creative activities. So within the school day, we know that school kids are getting a lot less time to do both physical activity, but also creative activities. These are the sorts of things that have been cut in the school day. So the more that we can get our school kids busy cognitively, emotionally, creatively, and physically, outside of ideally within the school curriculum, linking up with community partners. And again, there's some fantastic examples of this, like the Forest Schools Initiative, organisations like the Trust for Conservation Volunteers. There are lots of great organisations out there, the Wildlife Trust, who do really brilliant work around connecting people with nature and the outdoors, and partnering with those sorts of organisations, identifying if there are community organisations near you, near your school, and linking up can be a great way to tackle that. And it doesn't need to happen through a social prescribing referral. It can just, you know, happen through lots of this work that we're talking about actually happens outside of a formal referral pathway. It's just about living a much healthier life. And again, just by being more active in your community. It could be about, you know, getting a farm or linking up with a city farm. It could be about doing some gardening or an allotment in your schoolyard. And there's some brilliant examples of schools that have been doing that, linking into healthy eating. And again, there's loads of brilliant community organisations who are already set up and are delivering this sort of work. So it's really worth checking out what is in your local community. And again, that's where a link worker may be able to help, but also your local NCVO, the National Council of Volunteering Organisations, they have local organisations, local offices, local reps. So it's worth looking. The local authority often keeps a list of the local community voluntary organisations within your geographic area. So start with that and go from there.
Excellent. The subsequent question is still on the schools and education organizations. It's more about, is there work being done to address creative health needs in early life?
Yeah, I mean, so I'm sure that there are, and there's some brilliant studies. In fact, our own Daisy Fancourt here at UCL has done really brilliant work around young mothers and care for young mothers, particularly those experiencing, for example, postnatal depression, and how, for example, singing can be used to support both the mother but also the baby, you know, to live more creative and happy lives. I think the big challenge for creative health is a sort of catch-all term that refers to anything that might be going on in the community, and it's a mosaic and a really complex ecosystem. So no one area, I live in Camden, I live in King's Cross, no one area is the same, you know, so South Camden and what is available is very different to North Camden. And that is the case for all of us. You know, we're living in areas that have a whole mix of different organisation and assets and spaces that are available to us. And I think for a lot of individuals, it's sort of accessing those services and knowing what is available. And that's, I sort of think and hope, where opportunities, say, around social prescribing can help. But like I say, I don't think we can just rely on social prescribing. Link workers are already under a lot of pressure. So it's got to also be about all those different services, healthcare services, community organisations, I guess, being more visible and thinking about how do we reach out to those individuals who need it most in communities. And this is why I always go back to the community organisations, because they really do have brilliant experience of understanding how to target those individuals. And you know, sometimes that can be, like we've seen in the pandemic, organisations shifting their entire provision to doing, for example, phone calls and doorstop stops to go and you know, just knocking on people's doors and asking if they're all right. And you know, new charities and new pop-ups between links, say, between food banks and these at-risk registers. So I think there are routes to tackling this, but it does require new ways of working. And that is a challenge, I think, for some of these organisations, you know, because if you think about a museum or a library, or an arts centre, they may not be funded. You know, their primary funding is not to tackle health inequalities. It's to look after a collection or to look after a space and to make it available to people to come in and use that space. So tackling health inequalities requires that really intensive work. And it's only through then partnership with those organisations locally that have that experience that I think we'll see the real benefits of these sort of creative health partnerships coming through.
Helen, this is proving extremely popular. The questions keep on coming in. We will run out of time, I think. Yeah. So the next one, the next one is from Jacqueline. She says, thank you for answering men versus women question. Also, do you think there are opportunities for linking arts and sports activities?
Yeah, I do, absolutely. And it's been really interesting because I come from a zoology background, but worked in museums for a long time. So I've always understood, I guess, the links between arts, nature and creativity in the outdoors and the physical elements. And our research, the key aspect of our research has shown that actually when you have three components, physical activity, emotional engagement, and cognitive engagement all happening at the same time within an activity, that's where you see the biggest health benefits, whether it's on a physiological data or psychological well-being self-report data. So I think really brilliant opportunities around that. And a lot of actually the work that lots of the organisations do within arts sector, artists, actually does have a big link to nature and getting people physically active, and vice versa. You know, a lot of the work, I mentioned things like the Wildlife Trust, they've been doing brilliant work around this for a long time. A lot of their work actually has a big arts component. So it's about getting people outdoors, but doing creative activities. That might be doing drawing or creative writing, writing a poem inspired by nature that you've following a walk, or, you know, doing healthy walks and linking up over a particular heritage site, for example. So I think there's really, yeah, definitely opportunities, and it's something that we're really keen to explore more. In fact, we've been having wonderful conversations with the Valuing Nature Network, and there's another nature network about exploring more links between arts, nature and creativity.
Okay, so perhaps one or two more questions. So the next one asks, can social prescribers be employed directly by NHS organizations and so benefit from NHS pension, etc.?
So in terms of the referrals, is that a referral question? Can you just start say the beginning bit again?
So it says, can social prescribers be employed directly by NHS organizations?
Yeah, so and many of them are. So many of them might be employed by a GP's practice or a primary care network, or they might be employed within a different aspects of a local authority, or indeed sometimes they're employed through a voluntary or third sector organisation. So that, I think, is one of the challenges for link workers. They often have, they're often within an organisation that may have very different priorities and may not, you know, social prescribing isn't their main function, if you like. And so that, I think, is one of the challenges also in terms of then accessing the sorts of support that they need. So typically a link worker might be employed by the NHS, they might be employed, say, through a GP's practice or a primary care network. But many of the social prescribers who've been around for a long time and been doing this work for a long time have often been employed by a third sector voluntary or an arts or a community organisation. And so we've got lots of individuals from very, very different backgrounds working across this space. And I think, you know, they do obviously learn loads of great stuff from each other, but I think that does make it challenging for those individuals in, I guess, really understanding the parameters of their job. And it is such a complex ecosystem because these then referral pathways look really, really different. But yes, the short answer is they can definitely be employed by the NHS, and many in fact are.
Okay, so checking the time, I'm going to choose another question. Okay, so top of the list now is a question from Lucy and Anne. So funding is often for project innovation. Continuing funding is often unavailable or traumatic for individuals who have learned to rely on it. Is there a solution there?
Well, I've got some radical solutions, but I absolutely agree with Lucy Ann. I mean, this is a major issue for many of the organisations that we've worked with for a long time, whether it's a museum, whether it's an artist, an arts organisation. They're all delivering these amazing programmes on very often very small budgets with time limited expenditure. So embedding it into core strategic work has traditionally been very difficult for a lot of organisations. What's been really good is there has been a shift, I think, from organisations, say, that are funded through Arts Council, where there is a move to integrating more of this sort of work as, if you like, a core part of your everyday delivery. And I think that is what we've got to move towards. But like I said earlier, many of these organisations, their core function is not to tackle health inequalities. Henceforth, their funding is not meant to, it does not fund health inequalities work. So any work that they want to do in this area, they're always looking for this, you know, for short-term project funding, when what they really like, is some core delivery funding. And that is going to be the case even more as we see more and more social prescribing referrals. And lots of those individuals that we've been speaking to in those organisations have been talking about the challenges around that. So great to have an uplift in interest and people wanting to access your services, but where is the resource to help support that capacity? So here, I think, is really where we've got to see a massive shift, and it requires a major shift in the way that organisations are funded and managed. That requires, at the topmost levels, you know, a lot more cross-government working. So at the minute, we've got all these separate departments of health and social care, Department of Culture, Media and Sport, education, housing, ministry, justice, all communities, all separate. And yet we know that if we really want to tackle health inequalities and level up, that it's only through this partnership working and partnership funding that that's going to work better. So we know that just throwing loads more money at the NHS isn't going to stop those individuals who are what might be called revolving door service users still accessing more and more services because of the challenges they're facing in their life. So we've got to do it differently, but that requires funding it all differently. And so that requires funding those community assets, our museums, our libraries, our art centres, our green spaces, our parks differently. If we genuinely want to integrate them into better service provision, they have to be funded on an equal level and an equal footing, and they have to be valued in that way. And I think there are going to be opportunities around that. We're seeing increased commissioning for those sorts of services from the NHS, but obviously the NHS has, you know, a limited budget and increased pressure on their budgets. So it can't come from the NHS directly. So it has to come from, I think, a complete rethink of how all of those different organisations work together and critically how they fund all those different services. And for me, that has to start at the top level of government departments and how funding flows into local authorities.
Fantastic. It's 2 o'clock, so sadly we will have to stop here. But just to let you know, in case you want to go on Slido yourself and have a look, there are plenty more questions that have appeared, and really fascinating talk. And thank you for taking the time to answering so many interesting questions. So thank you everyone for being with us today, and thank you again, Helen, for such a great discussion today. So if you want to watch more lectures or listen to the UCL podcasts, please visit the UCL Minds webpage. And for today, we are done. So stay well and goodbye, everybody.
Thanks, everyone.